Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev, and together with Abzal Jumabekov and Sheikh Mohammed Khan, we are from Presidential Hospital in Almaty, Republic of Kazakhstan, and now we have patient number 2. Андай ревьюда көретін несі бар, режим. Okay, Abzal is continuing the case. Marmari? Okay. Now it's more comfortable. This is a common carotid and the vertebral artery. Mostly common carotid. We did this more selective angio. You can see the branches from ascending pharyngeal and the occipital arteries feeding the territory of dural fistula. And the draining veins is going to the cerebellum on the right side, and then going to the left side. It's a pure cortical venous drainage. You can see now clearly. This is an occipital artery, no meningeal artery, but might be this one is meningeal. But it was look like ascending pharyngeal artery branches. No, it's a meningeal. It's a meningeal, and it's going a little bit from the dangerous territory. But if it's possible, we can go there. The occipital artery territory is more tortuous, but I think it's possible to go with the headway duo. Also, there is a supply from the PCOM and PCA. Couple of branches going to the dural branches, and this one is going to the territory of fistula. And now we can see clearly the draining vein. There is no sinus. Sinus is clear. All is draining to the Vermian veins. The right side posterior meningeal artery. It's quite tortuous. At this point, usually there is a coiling. It's one of the possible branches to go. Why not? It's possible to go from this branch, but it's quite tortuous. Okay, let's see. And then, yes, it's a hypoplastic and going directly to the posterior meningeal. Now Abzal will go to the left side, and also there is a specifics of the anatomy of meningeal artery. Meningeal artery coming from the ophthalmic artery here. It's a recurrent meningeal from the ophthalmic, and it's supplying the territory of middle meningeal artery, and then it's going to the territory of fistula. I'm not sure we should go there. The PCA looks more straightforward, but it's also the branch. This branch is going. It's quite small and going from this point. It's something small, yeah. Okay. Maybe we can go from more secured meningeal territory. It's better, I think. Yes, this meningeal is better on the left side. Let's see. There is the occipital artery enlarged, and this is the meningeal. This meningeal is also goes from the ophthalmic. You can see it's coming from the ophthalmic artery. Yes, it's going from here. The ascending pharyngeal is, I think it's a branch of ascending pharyngeal. Yes, it's part of ascending pharyngeal. I think we can go from the occipital artery on the right side. Let's see the rest of the angiography. The plan B is microsurgery and clip the draining vein. That's also the possible option. Yeah, Abzal did the angiography from the external carotid. Because of the spasm, it's not so nicely visible. There is some branch going there. Левый позвоночник корривер, Абзал. Высокий режух. I think the vertebral artery on the left side will be also hypoplastic because of the both picoms coming from the picom territory, and there is a small meningeal, inferior meningeal meningohypophyseal trunk is going also to the territory of the fistula. Okay. Okay, let's see the left vertebral. The first patient was extubated and planning to switch to the department. Everything is okay. The first patient was extubated and planning. Кастратор. О. Я троюсь. Кастратор, бір секунд. Сейчас я переставлю. Okay, now we can see the territory of left vertebral. This branch might be useful. it's going in parallel, but usually at this point it's very tortuous. We can go laterally in the same draining vein. The single vein is going from the maybe two veins, and then we see the projection. Okay. It's poorly seen the PCA territory because both PCA comes from the... Yes, this point is very tortuous. It's very tortuous anatomy. With headway duo it's reachable, but okay, let's compare the occipital territory. Maybe it's better to go from occipital, those occipitals, and there is a something like meningeal. This one is meningeal. It's going here and then it's going there. It's really hypoplastic, huh? The same territory. But at this point I think we should place two sheaths. We need to place 6 French sheaths on the left side and take out the... We have 2 guidings now, narrow max and inside Hyperion 6 French. We will take narrow max to the right external carotid territory to go to the occipital branches. I think we can go for this branch. Headway duo should do all these curves. I hope so. Option number 2, it's possible to bring the scepter mini, but I think headway duo is okay with Traxxas. Headway duo, Giselle Alta, Traxxas. Екінші introducer alt French. Сол жағынан. The second guiding catheter we will place in left occipital, left vertebral artery for the simultaneous control. Also, this branch is coming from ascending pharyngeal, and at this point there is a network is going to the fistula. We did navigation for the meningioma in many cases. Sometimes it's possible to go. At this point it could be a little bit tortuous, but at this point, let's see. It's not non-eatable meningioma, AV fistula. I'm still with the first case. We also have a possibility to go through the ophthalmic artery. Yeah? Okay, let's check the ophthalmic. It goes like this. It comes from here, not quite straight. It's possible to take sonic 1.535 and to go there. 1 curve, second, third, some tortuosity here, but it's possible. If it's necessary, we can go from the ophthalmic, but it would be the last plan, because the ophthalmic artery usually might be risky because of the retinal artery damage. Huh? Okay, let's try to do it more safely. Okay. Переключай на общий экран. Okay. I asked Abzal to place the second introducer sheath on the left vertebral, left femoral, and then we will place it in the vertebral artery for the better control. Yes, and today is Sunday. I like Sundays because medical staff is more relaxed and there is no patient coming from outside. Usually it's more comfortable. Çok canta olsun. Так. Ну, интродюсируем. Функциональный блок и проводник. Мага салон тесен. Okay. Yeah, koyuyorsun. Traxxas жупичный слой. Okay. Let's place the 6 French sheaths on the left side. Yes, you couldn't see us, but I hope you could recognize my voice and I think the blood pressure is quite low. There's very bad pulsation because of the blood pressure is 86. For those cases, better to have a ultrasound. Yes. The patient is male, 60.
Система Зои. Yes.
There is a problem with blood pressure. It's more comfortable for the embolization, but it's not so comfortable for the puncturing. Finally, we are inside the artery. Okay, let's check. Боковой труб. Yes, we are in the artery. Patient with the extra weight. Чуть-чуть ожирение сварганы. Абзалана пункционный иголка на обсесиш. Я лахтрасал. Что брюджите?
Каждый кайтон.
На осылай болады. Бір с хвостиком болса сұрайсың? Біреу с хвостиком. Так, ну қайда тұр қазір?
Мынау неде тұр? Позвоночек. Позвоночек дегенде отлично.
Okay. We should move from the subclavian on the left side to the Sonic жоқ, Sonic емес, Headway-ду 156 и Traxxas. Болды, жетеді. Сол жетеді. Y-коннектор с хвостиком бере сал.
Y-коннектор.
Окей. Ана не X-ray қойсын. Окей. Now I have a Neuromax, and inside the Neuromax we have a 6 French coronary guiding, which is Hyperion. Hyperion is a Asahi guiding catheter. That's what I say. Need to go to the ICU territory. Okay. Родно, переса. Родно. Родно. Екі жетеді осы. Okay. We don't need to go to the maxillary artery. I think it's better to stay in office of occipital. It's a lingual artery. It's lingual. It's going all the time to the ascending pharyngeal. Okay. Just a second. If it goes there, let's check it. Let's check how the ascending pharyngeal is behaving. Okay. Just a second. Let's put it to the big screen. This is how the ascending pharyngeal is look like. It might be good, but usually here we have some tortuosity. Just a second. Let's do it cranial. Let's take it out. Назад, назад, назад, назад, назад, назад, назад. Okay. It could be a good candidate, huh? It could be a good candidate. Just a second, we'll take out the 6 French and дай да қойған ой коннекторды бере сал. Қазір мынаны алған кезде соны бере салсын.
20 коннектор.
Бере сал. Кере жоқ. Yes, now we took out the 6 French from the Narrow Max, and now we will go to the Джерри. Или Балтик высыл. На всякий случай. Because we used to use экранды бір 10 сантиметр өзіңе тарта сал. 10 сантиметр. We used to use Y connectors from Bolt, that's why we're saying Bolt Y connector. Sure. Что? Оно каптит в отрой, да? Принес. Так, стоп, бред, стоп. Проводник вперед. Price testing in occipital territory. Roadmap görüyorsunuz. İsmini. Экранды 10 сантиметр от меня жасайсыз. От меня. Отлично. Yes, it's okay. Now the screen is in comfortable position and the second guiding is in the vertebral artery. Осылай болады. Okay. Let's check the... Ана шейкерді қайтан азайтып қайтан... Ой, блин, мынау қарамапсың ғой. Абзал. We had some a leak from the Y connector because of the click Y connectors. It's okay. Не опыт. Анан азайтып қайтадан көбейтсе. Азайт. Жай. Жоқ. Мынаны бүйтіп азайтып қайтадан көбейтсең, солай дұрыс болады. Жоқ, азайт. Осылай пойдет. Пойдет. Ішіне төсейсің. Okay, now let's do angio from vertebral and then we'll check the PC. Okay. Bir 3000 гепарин беріп қоя салсыншы. Назад. Вперед. Стоп. Назад. Smart mask. Okay, let's try to go from this. Maybe this will be more comfortable. And let's check the... Okay. The guiding is now out from the... Назад. Вперед. Okay. This is for control, that is for navigation. Okay. Okay. Let's go through the vertebral and then if it's not, then we can go through the occipital artery. The ascending pharyngeal is not bad candidate also, but let's see. Okay. We have lost the roadmap from the... Ана шейкер қырылдап қалды. Свежий не саласыңдар, Оникс. Сквит. Okay.
Точнее, просто так, что aslında rezil sırası bekliyor.
Okay, maybe this branch is better. Hangi grafin koyuyorsun?
Tamam.
Hangi grafin koyuyorsun? Just a second. Just a second. Okay. Just a second. Now we have something here. Then we can go to the territory. I think it's possible to work from here. That branch is quite tortuous, this branch, and the catheter is simultaneously went to this territory. Ой, ёб твою мать. Не oldu mu? Мен тиген жоқпын ғой.
Басқасынан істейсің.
Okay, our Y connector is leaking. It was a bad surprise. It was a Riva Y connector from bulk. It was leaking without pressure. Okay. Բայց կոնտի կուտ կնշանա. Okay. Now we're somewhere in the branch. Okay, let's check. Abzal? Okay, we have flashing system. Headway do with Traxxas we used for the navigation in the posterior meningeal branch. Yes. Now it's look like we're somewhere. Huh? There is a bifurcation, that's why I don't want to go more distally. I think this point is okay. Okay, squid. I think squid 18 will be better. Squid on 6. Да, екіншісіне сразу squid 12 жинап қоя саласыңдар ғой. Okay. That's the same draining vein. Обезболить, обездвижить будет очень больно. Наркоз поглубже. Так, бері сал. Екінші шприц жинай бер. 12 жинай бересің, екіншісі. Екіншісі 12. Yes, and we should keep in mind about the supply from the PCA territory. This also could be the surprise. Okay. There is a lot of collaterals, that's why we should be very careful. Huh? It's going to the other PCA branches. Екінші катетерді қойырыз. Ешкі скөйт.
Okay.
Тағы да жеңе бер. Скөйтіп екеуін араластырсын.
Араластырып.
Those are all collateral branches. Okay. Пока жетті. Новый roadmap. New roadmap. Roadmap қайтадан қойасың. It looks like there is no more fistula. No fistula. Okay, let's check the outside. Let's check the vertebral artery. It looks like no more fistula, but we should continue a little bit. Назад, назад, назад. Снимок. Назад. Вперед, вперед, вперед, вперед. Вперед. Yes, okay. The small portion from the PCA is coming. Okay, let's occlude a little bit extra. Now it's the branches from the bifurcation is come. Yeah? It was the bifurcation on this branch. Here was the bifurcation. We went here, and it's coming here, and now we have the reflux still here. It's quite acceptable. Till now, it's a 1.5 centimeter, nearly 1.5 centimeter reflux, and I hope we can finish. Huh? This vein is this vein till this point. On AP, we occluded till here. Also good. Yes. We will give a little bit more, but I will wait a little bit longer. Huh? I will check the right side, and I'm not sure we need to check the left side. But we can check with the. It's a ICA territory. There is no more meningeal supply. I think the left side is the same. Okay, now I will bring my Neuromax back. And we can do angio from here. Nie nasze? Proszę, kieruj. Yes, it's okay. I will take out my Neuromax. Just to have less sources for emboli. Okay, let's give a little bit more. It's also refluxing and also going to the MMA territory. Okay, let's do one more run, check, and then decide. Yes, the branch is no more supplying, and you can see the venous congestion now. I think we should keep on heparin 1000 per hour to prevent the venous reflux, a venous infection. Right.
For 1 day?
That's better. For 1 day, then we will follow with the low molecular heparin for 4 days. 4-5 days, yeah. It may cause the symptoms. He should be on heparin. Okay, let's inject a little bit more and then we can finish. Yes, the right PCA territory. On the previous angio, it was normal. Huh? It was a branch going to the fistula, but it's not more functional. It's good. Rodo. Okay. Yes, the injection could be from anywhere, but because of the straightforward artery, we decided to take this branch from the posterior meningeal. The navigation was quite not so complex, that's why. Yes, but if there is a middle meningeal artery available, for me the first choice is to go from the middle meningeal. But in this case we had no middle meningeal directly coming from the extracranial circulation, that's why we navigated from the vertebral arteries. Vertebral artery on the left side through the posterior meningeal. Maybe it's a time to finish. Huh? Okay, let's see. A little bit more injection. Okay, this is a posterior meningeal coming from the left side. It's a big branch, and now we can finish. Just create negative pressure. Не oldu. Sonday pacient chodí, ne? Sonday pacient chodí. Okay, I'm pulling the headway duo slowly. We know the characteristics of this catheter. Yes, that's kind of without high force. It's possible to retrieve. Хай там хвесно. Хай там тугисаш. Тугисаш хажет. Okay, let's do angio. Just a second. Okay, let's put it like this. Down. Back. Okay, let's do one more time from the proximal vertebral to exclude the possible vertebral artery injury. Yes, everything is clear. The posterior circulation is okay. Now I took out my guiding and I'm asking Abzal to do control angiography. Control XPER-CT. Yes, it was both side approach. Okay. Okay, let's wait for the XPER-CT. Castrator. Câte jasasın? Oh. Ne trăiosă. Okay, let's wait for the control CT. Microphone is still on. Stimulk. It's not started. Okay, now CT is coming. It's a 5-second acquisition. Let's see how it's look like. Today is the day of posterior fossa from the morning. Okay, the CT is ready. Câte în ортаға қоясыз, Абзал? Yes, no problem. I think it was before, huh? Patient had Много қашан болған, Абзал? Patient had the ischemic stroke. In anamnesis, patient had the ischemic stroke. Okay, now it's clear. Okay, it was a hemorrhagic stroke. Yes, no complication. Now we can finish. Last year it was a hemorrhagic stroke. It was a hematoma evacuation. Trepanacea. Okay, let's see like this. Yes, it was. Ah, no, it wasn't operation. It was a ischemic stroke on the left hemisphere, and I think at that time it was done angiography, and this pathology was diagnosed. The stroke was in December. Okay, but there is no sources for the ischemic stroke from the arterial side. Okay, let's check it again. Абзал ревьюді қоясаш ортаға? Review. Okay. This territory is quite clear. That territory. Okay, let's check it. Yes, the left side looks. There is a stenosis. You see? Stenoz бар ғой мына жерде. Okay. Okay. There is a symptomatic stenosis. Okay. Okay. We will recommend carotid stenting in 2 months, maybe next month. Okay.
Хеморрагический супроники.
Maybe it was a hemorrhagic transformation, eh?
Ну, МРТ сделали. На МРТ пишут геморрагический инсульт.
Okay. Okay, we should check and revise the previous images. Okay. The fistula is completely occluded. Now we can finish and see you in next 30 minutes. Next case is a patient with meningioma, but he was previously treated abroad for the fistula, arteriovenous fistula. We will check both the fistula side and the meningioma side, and yes, patient already has a peripheric upper monoplegia on the left side. We will see. We will see. Okay. See you in 30 minutes. Thank you. Wish you well.